Okay, good afternoon again, and I'm glad that there are still people around, and I admire their presence, particularly Dr. Al-Mkhlafi. So the topic I was assigned to give this time is post-cardiac arrest management. And given the fact that it is already almost 4, I'll try to make it as light as possible, and I'll try to focus on certain points. So this is my presentation outline. I'll talk about post-cardiac arrest issues, therapeutic hypothermia, the start of this intervention, particularly with the HACA and Bernard trials, then solving the puzzle that, TTM trial, Princess trial, the TTM 2019 trial. New ideas and conclusion. So I hope you can really keep it up with me. So starting with the first thing, post-cardiac arrest issues. We know that there are so many, issues that come in light after cardiac arrest, after return of spontaneous circulation. So the thing you want to do is to prevent further cardiac arrest, right? You want to find what caused the cardiac arrest. You want to limit organ damage, particularly the computer. And you want to predict mortality or non-survivors. Now, for the first aspect, which is prevent further cardiac arrest, you want to optimize oxygen therapy, you want to prevent hyperoxygenation. Saturation of 94 to 98 is considered accepted, and titrate oxygen down if not needed. Protective lung ventilation is important, sedation, normocapnia, and correction of any electrolyte abnormality, and good glycemic control. And if the patient needs, then antiarrhythmic medications should be given. The second part is, treat the underlying pathology that resulted in the cardiac arrest. So diagnose and treat the cause. If the patient had MI, then PCI or thrombolysis, for example. Treat complications. Patients after cardiac arrest usually have or suffer many, many complications, including heart failure, shock, pneumothoraces. So treat these. Now, if your patient has persistent cardiac arrest, then consider cathing the patient, or more importantly nowadays, eCPR or VA ECMO. Now, the CNS, the computer, is the most important. If the brain is not functioning, whatever you're doing is probably not very useful. The third part is limit organ damage. And as I've mentioned, CNS is the most important. So if unconscious despite return of spontaneous circulation, then consider targeted temperature management or therapeutic hypothermia. You have to control shivering, avoid fever, controlled slow rewarming at this particular rate in most studies. Many of our patients after arrest, they develop myoclonus, seizures, whatever. Control that. Invasive monitoring is sometimes needed. Inotropes, vasopressors to maintain a blood pressure good enough to allow good perfusion of the brain is important. So let's focus on the first part, which is therapeutic hypothermia. So what do we have there? So therapeutic hypothermia and the start of hypothermia, especially with the HACA and the Bernard trials, is when we started actually putting patients to sleep and put them in hypothermia after cardiac arrest. And this is the HACA trial that was published in 2002 in the New England Journal of Medicine. It was a landmark study at the time, and it is in fact still. And as you can see, survivors are more with the hypothermia as compared to normothermia. And if you go into the dissection, the conclusion of the study, now the temperature they chose is 33 in average, which is 32 to 34 in the study group, as compared to normothermia. Total number of patients is really good. And mortality was better in the hypothermia group with a good p-value. Similarly, a favorable neurological outcome was better in the hypothermia group, as you see here. So, in fact, this is out-of-hospital cardiac arrest, and the hypothermia was applied for 24 hours only. And they chose for favorable neurological outcome in all the studies that I'm going to mention from now on the CPC scale, which is the cerebral performance category. CPC 1 and CPC 2 are considered to be good or positive outcome, while 3, 4, and 5 are negative outcomes. Now, moving from the HACA to the Bernard trial, which was published amazingly in the same journal and in the same issue. That was February 2002. But you could tell from the two studies that Bernard trial is far more inferior compared to the HACA trial. The total number of patients only 77. Again, same temperature range in the study group, normothermia in the control group. Again, there is less death in the hypothermia group, but didn't reach statistical significance, while favorable neurological outcome was better in the hypothermia group, which was, just statistically significant. Here, they started hypothermia 2 hours after return of spontaneous circulation, and they continued it for only 12 hours, and again, it was out-of-hospital cardiac arrest. Now, solving the puzzle, this is the most important thing. From these two studies, from 2002, created for us the following puzzle. Number one, what is the best duration of hypothermia? What about patients who have cardiac arrest because of a shockable rhythm as compared to those with non-shockable rhythm? Is there a difference? If the patient is admitted to the hospital and developed cardiac arrest, is it the same as out-of-hospital cardiac arrest? What about the cooling device, external cooling methods or endovascular or other forms of cooling devices? Does it make a difference? If you can solve this puzzle, then you will have really, really good outcome. But we forgot two very important variables that we should really consider. What is the optimal temperature during therapeutic hypothermia? And the second thing is time to target temperature, okay? And if you can solve that, you will really do well. So let's start with the first thing, which is optimal temperature. So after the HACA and the Bernard trials, we had a third very important and landmark trial, which is the TTM trial, or Targeted Temperature Management Trial, from 2013. Now, this study has a really good number of patients, reaching 1,000. They chose the same temperature range with average temperature of 33 as compared to temperature of 36, which is not hypothermia, right? Wrong. 36 is considered hypothermia, but less hypothermia than the 33. So it is again therapeutic hypothermia. 36 is not normal temperature, it is hypothermic temperature. So mortality was not statistically different in both groups. Similarly, the favorable neurological outcome. So it was a negative study, unfortunately. And it was, again, out of hospital cardiac arrest, and they chose a period of 28 hours. I don't know why they chose 28 hours. It's crazy. They didn't say 28 hours and 5 minutes, for example. Anyway, so it was a negative study, but we can extrapolate from this study that hypothermia at a range of 32 to 34 is probably the same as hypothermia of 36. And which one is easier to achieve? Which one has less side effects? Of course, the 36. During or after the publication of this trial, a person or a physician have written this editorial, and his issue is that most patients reached their target temperature during hypothermia 6 hours after return of spontaneous circulation. And this guy is called Norberg. And in fact, when he published this editorial, he was doing a study. It was the Princess Trial. And the Princess Trial is really important trial. And he was trying to solve 2 puzzles in this particular puzzle. Number 1, the cooling device, and time to target temperature. And I think the guy has good intentions. And let's go over the Princess Trial that was published mid-2019, last year only. And it was a very nice trial, by the way. So at that time, the current clinical practice, and probably until now, is to do the CPR after cardiac arrest. When the patient has return of spontaneous circulation, the patient is taken to the ICU, and then there is a gap here, as you see. Then therapeutic hypothermia is applied, and then the outcome is evaluated, right? What he wanted to do is to close this gap completely. In fact, he wanted to start hypothermia right during CPR, which is really a clever way of dealing with this thing. And this is the principle of the Princess Trial. So let's see what they did. They invented a machine called the Rhinochill, which is this thing here. And this machine is connected to a tube. This tube is connected to a long nasal cannula. There is a vapor here or a liquid that once the machine starts functioning, it will spray cold fluid inside the patient's nose. So there will be reduction in temperature by both conduction, convection, and evaporation. So this is how the machine looks like in reality in front of a patient. And this is after the machine is applied to the patient. And as you notice here, CPR is ongoing. So you are starting hypothermia during CPR, which is really a good thought. Now, this Rhinochill was studied in 2015, and it was shown that it lowers the temperature very, very quickly in normal volunteers. And within minutes, you can reach the target temperature you want. And in the Princess Trial, what they did is that if there is out-of-hospital cardiac arrest, which is witnessed, the patients are, revived, and after return of spontaneous circulation in the hypothermia group, the hypothermia is started immediately during CPR, while the other patient, hypothermia, will be started only in ICU. So this is the usual practice. This is the usual practice. This is what the study wants to prove effective. Now, there should be, or there must be, bystander witnessed out-of-hospital cardiac arrest. The patient's age must be over 18. Exclusion included EMS response over 15 minutes, which is reasonable. And if return of spontaneous circulation happened before initiation of hypothermia, and if the patient is, elderly, then he's excluded as well. Now, the number of patients was good, and they were evenly distributed, and this is the outcome. It is out of hospital cardiac arrest, duration of hypothermia is 24 hours, and I want to really to focus here and imagine how efficient these people are. Imagine EMS started CPR only 9 minutes after the witnessed cardiac arrest. Does that happen in Saudi Arabia? Even at home, we don't do that. Airway management system is done 14 minutes after the cardiac arrest, after the onset of witnessed cardiac arrest, which is amazing. Randomization is done 17 minutes after the cardiac arrest. We take ages to do randomization here. And cooling is started 19 minutes after the onset of cardiac arrest. That is around how many minutes? Around 5 minutes after the start of EMS CPR. You see how efficient they were? Now, the target temperature was achieved in the study group around 100 minutes after the cardiac arrest and 182 minutes in the control group. They found that there is no difference whatsoever in the hospital VFib rate, cardiogenic shock, pulmonary edema, vasopressor need in both groups, which means that early initiation of hypothermia in patients with out-of-hospital cardiac arrest is what? Safe. All right. Patients alive at day 90, not statistically significant. What a big disappointment, right? Okay, let's see the favorable neurological outcome. Again, 16.6 as compared to 13.5, which is not statistically significant. Another big disappointment. Very, very unfortunate. So, if you look, now there is a very bright window here, and I want to show it to you. If you look at the subgroup analysis, they notice that patients who had shockable rhythm in whom they started hypothermia during CPR have good outcome as compared to those with non-shockable rhythm, which means that we may extrapolate that early application of hypothermia in patients with out-of-hospital cardiac arrest may be beneficial for those with shockable rhythm. Okay? Conclusion of the Princess trial. It is very well designed study. Intervention close to the onset of cardiac arrest was there. Transnasal cooling is safe and significantly shortens time to target temperature. Early initiation of therapeutic hypothermia does not clearly benefit out-of-hospital cardiac arrest, unfortunately. And those with VFib may benefit from early hypothermia. So this is the outcome of this study. And these are the 4 studies that I've spoken about put together. As you see, the HACA, the Bernard, the TTM, and the Princess trials. All of these studies are landmark studies. And I think this slide is really useful. So let's go back to our puzzle. So what did we do? Did we do anything good? Now, in late 2019, few months ago, a new study came and tried to sort out whether shockable rhythm or non-shockable rhythm has a favorable outcome with hypothermia. And this study, I named it TTM 2019, and it is titled Targeted Temperature Management for Cardiac Arrest with Non-Shockable Rhythm. So they did not compare shockable with non-shockable. So let's see the outcome of this study. And this is very important, and it will surprise you. I was surprised with it. Now, the target temperature here is 33, averaging 32 and 34 in the study group. Normothermia in the other group. Total number of patients is really good. Death was different and wasn't statistically significant in both groups, but favorable neurological outcome was better in the hypothermia group compared to the control group with, just significant p-value. Here, they applied hypothermia for 24 hours. So we thought that probably non-shockable rhythm will not benefit from hypothermia. Now, we knew that early hypothermia application and shockable rhythm from Princess trial is probably beneficial. Now we know for sure that patients who have non-shockable rhythm can have favorable neurological outcome as compared to the control. So guidelines are confusing. This is one of them from the American Academy of Neurology. And this is the ILCOR or ILCOR guidelines. And let me go to some new ideas and I'll end. This is a study that was published early this year. And it talks about high quality TTM. It is not actually a study, it is just some sort of proposal. They propose that based on the available data, we must initiate hypothermia as early as possible, intra-arrest if possible, transnasal if the device is there, not necessarily during CPR, but after return of spontaneous circulation. And the other thing, cooling phase from 33 to 36, not to 32. Measure core temperature, shorten time to target temperature, and they did not really discuss the duration very much, but 24 hours is probably appropriate. The other thing is methods during hypothermia. They suggested strict hypothermia without significant variability. Management of shivering is very important, and avoid side effects and treat them if they show up. And finally, post-cooling, slow rewarming, again, shivering management, and after rewarming, avoid fever. So this is back the puzzle. There are studies about time to target temperature, cooling device, shockable versus non-shockable, duration of hypothermia, and optimal temperature. There are no studies or major studies about in-hospital compared to out-of-hospital cardiac arrest. But time to target temperature, we don't know exactly what it is. Shockable or non-shockable, there is no head-to-head trial. Optimal temperature is still vague. Duration of hypothermia is still vague. Cooling device, we don't know which one is the best. In-hospital versus out-of-hospital. So basically, your puzzle is unsolved yet. Now, I'll try to solve it to you by my conclusion, and I hope this echocardiography, it's better than volume view. By the way, after my presentation, Dr. Ghalib told me, sorry, I said that because they wanted me to say that. This is what you said. So, target temperature, 32 to 36. This is what I would suggest. After this extensive review, I'll choose a temperature. Which one you think? 35. Excellent. Why 35? Because it is well below 36, and it is easily achievable. So go for 35. Take it from me. Okay? Time to target temperature, 0 to 6 hours. And where will you go? Huh? Excellent. Did you see my study before? So my slides? As soon as possible. Even if you can do it, during CPR, I think the sooner the better. Duration of hypothermia, 12 to 48 hours. We have 12 hours, 24 hours, 28 hours, 48 hours. Which one you will choose? 24 hours. 28 I don't know who came with this number. Oh, that's it. Who are you? You are too young. You should sit in the back. Front seats for the elderly. Subgroups. Will you exclude any of subgroups like shockable, non-shockable, PAA, asystole? So I'll include all. So I think this is what I come up with. And I feel this is probably the best recommendation you will ever see. If you go to the guidelines, they are very, very confusing. And thank you very much.